ENT. What does this mean? Well, in the medical world, it stands for ear, nose, and throat. I dare say that someone in every family at some time or another has had at least one of the following: an ear infection, some infection of sinus infection, strep throat, or tonsillitis. Why are they so common? And what are some of the other problems we could face? And what are the advancements in treating the ear, nose, and throat? We're going to break that down, the ear, nose, and throat, on this edition of Healthy Living. Stay with us. Hello and welcome to Healthy Living. I'm your host, Tammy Thompson. We're going to be talking about ENT on this edition of the program. Ear, nose, and throat, and all of the complications, all of the treatments that go along with that. And with me is Dr. Daren Kest, who is an ear, nose, and throat specialist here in Paducah. Thank you for joining me, Dr. Kest.
Good morning.
Let me just start out by having you tell me a little bit about yourself.
Well, my name is Daren Kest. I'm an ear, nose, and throat physician. I'm board certified. I practice out of Purchase ENT. My specialty, obviously, like you mentioned, is otolaryngologist, which is a fancy word for ear, nose, and throat. I have some subspecialty training in head and neck oncology surgery, which is a division of ear, nose, and throat, and that's related to the cancers related to the ear, nose, and throat. And
that's pretty special for this area, isn't it? Your specialty and your specialty.
Yes, I think almost all ear, nose, and throat surgeons during their training get exposure to head and neck cancer, but I've found an interest in that area and took it upon myself to do some additional years of training in that field alone to just hone in on that specialty as an interest of mine.
Okay, is that becoming more prevalent, cancers of?
Well, you know, it's probably not coming more prevalent, but because, you know, the tobacco consumption has pretty much stabilized throughout the country, and fortunately through a lot of educational means, many people are finding ways to quit. However, with head and neck cancer, the most common cause is related to tobacco use. So it's still pretty prevalent, especially in the state of Kentucky, in which 1 out of 3 individuals are using some form of tobacco product.
Okay, whether it's the dip or the smoking.
Correct.
Or
whether it's smokeless
right.
or smoking tobacco, and that has a direct impact on the incidence or the likelihood of developing head and neck cancer or throat cancer.
Okay, well, we're going to talk about the cancers that relate to each one, the ear, nose, and the throat, as we go through them. Like I said in the open, we're going to break this down for our viewers. We're going to start with the E, the N, and the T, so that we can kind of keep, because they're all so related, and you don't really understand how all of those, you get one thing, it kind of goes to another, and it just kind of goes down the line. So let's just start with the ear and how it's supposed to work and what happens when it doesn't.
Okay. Well, as we know, the ear functions as our means of hearing the outside environment. It's a specialized organ. It's extremely specialized, and it allows us to enjoy birds chirping, listening to music, conversing with others. So it is a very important organ in our body. And so when it's not working properly, it can be fairly disabling for people. As we know, in the elderly population, people, as they get older, the hearing nerve kind of gets weaker and doesn't hear as well, and many of those individuals necessitate hearing aids. And then in the younger population, the infants, we're dealing with chronic ear infections, which is separate from a hearing loss, but can affect the hearing and lead to problems related to the need for ear tubes, which we perform to help eradicate and treat that problem.
So the ear infections, what is, my favorite thing is the itis. At the end of every problem, there's an itis. So if you have an ear infection, what is the itis that goes with that?
It's called otitis. Otitis, when you have an ear infection, which is called a middle ear infection, that's the ear infection that's behind the eardrum, that's called otitis media. Itis is just a word, it reflects that there's an inflammation related to that tissue. So in oto is a medical word, it's a Latin word for ear, so otitis is just inflammation of the ear. And then when you describe whether it's an externa, meaning like a swimmer's ear, an outer ear infection.
And what does that mean? What is, if it's in that, of course you have the external, middle, and internal, so you can have an infection in each part of that?
Well, most people are very frequent during the summertime of developing a swimmer's ear. And a swimmer's ear infection is usually an infection that's related to the canal. That's the area where we put our Q-tips in to clean our ears out. That's the initial part of the ear in which sound is conducted to the eardrum. So that outer portion is called the external portion, so we call it otitis externa. And when you have inflammation and infection in that area, it most commonly can occur related to getting water that doesn't come out of the ear. It kind of stays in there and it becomes an environment that's conducive to bacterial infections, which can lead to the otitis externa, the swimmer's ear.
So my nephew has had lots of trouble with his ears, and the canal has actually swollen shut before. So that could have been anything, but the whole ear swells shut.
That is a swimmer's ear. That is
he'd been swimming all day.
That is very classic for a swimmer's ear infection, where the canal will swell almost completely shut, if not shut, and that would require us to use antibiotics, and mainly in the ear drop form. Sometimes we have to put even a wick, a type of like kind of candle wick type of thing to put in the ear canal, just to allow the medicines to get to the area of infection, because it can swell so badly shut from the outside that even putting drops in and medicines isn't going to get to the area that needs to be treated.
So you recommend because he'd had trouble his whole life, so he needed to wear those earplugs, and he didn't wear them that day. Is that something that most kids should wear? Should they wear earplugs? It's not just maybe the kids who have trouble.
I don't. Many times, this is not a big issue in the community. It has happened, and it most frequently happens to at least everybody once in their lifetime, at minimum. But it's not something it's not something we are overly concerned about, and we really feel it's necessary to educate the public about to prevent. So earplugs, for those who are susceptible, can be helpful in preventing. But however, the normal hygiene of the ear and how it functions physiologically, the fluid should come out and allow the ear to ventilate properly with the air and prevent those infections from occurring.
So it's more, once we get into the ear, the middle ear, that's the one you said that the otitis media, that's... The otitis media is just media meaning middle. And so that is somewhat of a closed space. However, it does communicate directly with the back of the nose. And just like you were referring to earlier, ear, nose, and throat, all those areas directly communicate with each other. So things that can happen in the nose can spread to the ear. And things that can happen in the throat and the nose, they all communicate. So if you have a sinus infection, you can develop a throat infection. It can also get up to the ear and cause an ear infection, because there's a direct pathway to each of those areas. And that middle ear space, when fluid gets trapped in there, it becomes an environment that's highly conducive to infection or bacterial growth. And because of there's fluid in the ear, and does that affect your balance?
Equilibrium, yes. Well, because right next to the middle ear is the inner ear, and the inner ear holds our organ for hearing and balance. So when you have any type of inflammation or itis in the middle ear, it can cause irritation to the inner ear, which can lead to hearing problems as well as balance problems and equilibrium issues.
Right. So let's talk about some of the things that can happen if you have chronic ear infections. And you said that it can affect your hearing. You can have hearing loss.
Right.
So what are some of the types of hearing loss that can happen?
Well, as an ear, nose, and throat physician, many people are familiar with coming to our office and getting some form of hearing test. And depending on the symptom or the reason in which they come to us, really we break hearing down into two components: conductive and neural. And what that means is, one is hearing being affected by how sound is being conducted to the inner ear organ, or is there something wrong with the inner ear organ impairing the person's ability to hear? So a conductive hearing loss can be anything like wax build up in your ear, or it can be fluid in that middle ear compartment, or some type of inflammation, or an injury to your eardrum. That can impair how sound is being conducted to the inner ear organ, and therefore impair some type of, or cause some type of hearing loss.
Right.
However, if there's an injury to the inner ear, that can cause a nerve loss that's a little bit harder to treat and has a little bit poorer prognosis as far as being able to fix that problem.
Well, I have a friend who had recently was ill and and his eardrums ruptured. There was a hole in it. How does that happen, and what is
well,
that?
Well, what happens is that the fluid can sometimes build up, and it can get infected, and it becomes a closed compartment, and so it's really pushing against all the walls. Well, the eardrum is the weakest point. And so therefore, in order for that infection to, it's kind of like an abscess, you know, and that's how we look at it. And that's why with children who get these repeated ear infections, we, in order to prevent that fluid from accumulating and becoming an environment that's conducive to infection, that's where those tubes are used. The tubes prevent fluid from accumulating and allow it to drain out. So if there's no tube in there to allow that fluid to drain out and it keeps on building up, it puts so much pressure on the eardrum, it can rupture.
Is that bad? Because can it cause scarring eventually?
It actually can help alleviate the problem because it's allowing the infection to get out.
No, I mean that if you don't have the tubes, and we're going to get to that, and the eardrum continues to rupture. Like my friend, he said it happened last year, it happened this year.
Right.
I mean, what happens when you don't have the...
Well, it can cause a permanent conductive hearing loss because if you get any type of severe scarring on the eardrum, which can stiffen the eardrum and prevent it and reduce its compliance, it doesn't work as well. So I kind of, when I explain to people how the eardrum can work, it's kind of interesting, but what it does is when you hear sound, you get a loud noise that gets broken down, that gets kind of condensed to the eardrum, and then the eardrum kind of is like a speaker that vibrates, okay, when it hits sound. And when it vibrates, it jiggles those little hearing bones, and the last hearing bone, each hearing bone gets smaller and smaller until it gets to the inner ear. And then it kind of acts like a little piston, and it goes back and forth and causes a waveform that stimulates the nerves that helps allow us to hear and dissociate sound. So if any point along that pathway gets injured, can impair hearing. So when the eardrum gets injured with a perforation or stiffening from chronic infections or various other different types of pathology, it impairs how sound is being conductive, and it can cause a hearing loss which may not be recoverable.
Right. You sound like an engineer.
Well,
you're talking about wavelengths and all. I was like, you sound like our engineer. He talks about that stuff too. You talked about smoking, and I bring in my family because we've all had trouble, or in my family have had trouble with ear infections, and smoking was a main factor when my nephew kept getting ear infections. They said, his doctor said, you're not allowed to smoke in the house. You can't smoke in the house around him because he's very susceptible to ear infections. Why?
Okay, that's a great question, and that's something that we really try to impress upon the parents of children that are brought into our office in which the parents smoke, because secondhand smoke exposure has been proven scientifically to have an extremely negative impact on the health and the well-being of the ear. And a child is developing, and the tissues in their nose and their throat are very sensitive to being irritated. So when the smoke, I give the example to the patients, parents, that if you pinch your nose and swallow, your ears pop. That's called the eustachian tubes that directly go to the middle part of the ear. And if the opening of that eustachian tube behind the nose is inflamed and swollen, it changes the pressures behind the eardrum, making the child more susceptible to infections. So if they're constantly breathing in secondhand smoke in their home or in the car, it's causing inflammation inside their nose, kind of like a sinusitis. That's the itis again, and that itis is inflammation, and that itis can cause swelling around the eustachian tube, which impairs how impairs how that eustachian tube functions, leaving the middle ear more susceptible to accumulating fluid and therefore developing a secondary infection. And when this repetitively happens, it can be, it can subject a child to surgery because of it, because after a while of taking antibiotics, getting over the infection only for it to recur again, we have to look at a definitive way of treating that problem.
Which brings us to the tubes. And my son had to have tubes in his ears. Neither myself or my husband, we don't smoke. But he had repeated ear infections, one after the other. As soon as he would have antibiotic, 10 days later when he got off of it, he would have another one.
Right.
So at a very young age, he had to have tubes, which is very scary for us parents.
Right.
That first taking away and that's very scary. But it was necessary because he could not, his ears just could not drain like they were supposed to in that fluid. So explain to me, how do you know that he needed tubes? My other friend who's had lots of trouble, his doctor said he didn't need them.
Well,
who needs them?
That's somewhat, basically there's certain criteria that are involved in whether a person becomes a candidate to have tubes put in. And there is in the pediatric and ear, nose, and throat fields, we have certain standards in which we go, and not, having one infection or two infections would not necessarily subject a child to requiring tubes. However, if it's happening 4 or 5 times a year, they're on constant antibiotics monthly, or if not more often, then there's potential negative effects on that form of treatment, as far as children becoming resistant to the antibiotics or having side effects associated with those antibiotics. We're looking at more of a definitive way of managing it. What happens is that behind the eardrum is a space like we talked about, and it's filled with air, naturally, a healthy ear. And that space, that air is equal to the same pressure outside. And the only way it stays equal is through that eustachian tube behind, in the back of the nose that we talked about. Well, in babies and infants, their skull isn't the same shape as ours. And our eustachian tubes are angled down, which makes it drain more easily. But on infants and small children, theirs are straight across because of their skull hasn't properly grown. So anything that could potentially cause further problem with the eustachian tube, like secondhand smoke or sinus and allergy problems, can impair how that ear space is functioning physiologically and letting air in there. Once a child develops a certain number of infections, and the pediatrician who's managing that child feels as though he's exhausted every measure in trying to resolve this problem, they send them to us, and they are considered candidates to put tubes in. And all the tubes basically do is kind of take the place of that eustachian tube behind the nose until things get normal again. And it allows air to be air that is equal to atmospheric pressure, equal to outside environment, because there's a direct communication through the ear canal.
So the draining of this fluid helps them not get ear infections anymore?
For the most part, yes. It prevents the accumulation of the fluid behind the eardrum. It allows the infection to drain out, and therefore it makes the middle ear space a healthier environment.
And as they get older and they're, what did you say the tube was?
The tubes are inserted in the eardrum, and ideally, we inform the patient's parents that the tubes will more than likely stay in for approximately 18 months to 2 years. And in most circumstances, they will extrude on their own.
Okay. And you talked about the antibiotics and how that can become a problem when they're continuously on them. There is risk with you know, the surgery. But it would do you think it outweighs the fact that they just continue to have repeated ear infections and?
Right. You know, there's always risks with procedures, and that's one of the reasons why we determine when they become a candidate, when the risks of the surgery are less than the risks of the alternative treatments that they are already undergoing. And so with frequent use of antibiotics, you can subject an individual to potentially develop resistance, you know, the organism to become resistant to that antibiotic, or the side effects themselves of that antibiotic to the person, which could be a multitude of different symptoms. And the pediatrician usually gets to a point where he feels he's exhausted all his options prior to referring them to an ear, nose, and throat physician.
Okay, well, we've finished the ear, I think. Is there anything that we didn't cover in this segment that you would like to say? Anything that we didn't cover? No,
I think that for the most part, the basic issues regarding the health of the ear we've discussed.
Is to protect your hearing, you know,
Yes,
that's
right.
and all of these things that we talked about. We're going to take a break, and we're going to move on to the second letter, the N, and we're going to bring on another doctor with Dr. Kest, Dr. Resser. So stay with us. We'll be right back. Welcome back. Our other guest, Dr. Daren Kest, was called away at the break. So our new guest that we spoke about is Dr. Randall Resser. Thank you for joining us, Dr. Resser.
Thank you
Just
for having me.
tell me a little bit about yourself.
Well, I'm an Ohio boy. I grew up in Ohio, went to the University of Cincinnati for my medical school training, and then went to Vanderbilt for my residency in otolaryngology and head and neck surgery. And I've just recently completed a fellowship training in our American Academy of Otolaryngologic Allergy. So
That's a fancy word.
Yep.
Sure is. Big, long word.
That's right, that's right.
And we talked with Dr. Kest before he got called away about the ear.
Right.
And we're breaking it down for our audience, the ear, the nose, the throat.
Right.
And we're going to do the throat, and I got a couple more questions for you about the ear at the end that we didn't get to with Dr. Kest. But besides the obvious, what does the nose do for us, besides just, of course, we breathe?
Certainly, it's what we breathe through. It has a bunch of different functions. It allows us to humidify the air that we breathe in so that we aren't drying out our lungs. It also allows a lot of moisture to get into our air, so we can go into the negative 20 wind chill factor in Ohio where I was growing up, and we won't freeze our lungs so much. It also acts as a little bit of a filter too. If there's a lot of particles in the air, it tends to get trapped within the convolutions of either the hairs of our nose or the convolutions of the structures of the nose, so we don't just have that impurity go directly into the lungs to some degree.
Well, see, you don't really think about it like that. You think you smell, you breathe, but it's a direct correlation to the lung, and it protects them. I never really thought of it like that before.
You can really think of the lungs, the windpipe, and the nose and the sinuses all as really one organ. They all have similar but dissimilar functions. Some of the mucus that we make down in the lungs is essentially the same thing that we have up in our sinus cavities and up in our nose. When we have an infection in the lungs, it'll make the sinuses and the nasal cavity run. If we have an infection in the sinuses, then it's very often will trigger some of the coughing or some of the wheezing that we might have in the lungs.
So again, we've talked about how all of this is correlated together.
That's right. They've been talking recently in some of our circles about the unified airway, the fact that everything is so interconnected. And in the past we used to think that asthma was a separate disease from allergy and sinuses, but more and more we're realizing that the way the lung really functions is related to the sinuses and vice versa.
So we'll talk a little bit about what happens then when that humidifier that you say, I didn't even think, we have our built-in humidifier,
right.
doesn't work properly.
Right.
What happens?
One of the things that happens is the nose is a very reactive organ. So if we have inflammation for any reason, if it's allergy, if it's because we've been around, certain chemicals that might irritate it, or if there's an infection in there, it tends to react to try to protect the body. And so the blood vessels of the nose are very reactive blood vessels. When we have this inflammation, they open up and they fill the structures with blood, which causes that congestion that people feel. It makes the structure of the nose really swell up and blocks the breathing passage. It also triggers the way the mucus is made, so that if those irritants are there, the body's making mucus to try to get rid of and expel those particles that we don't want in our system.
So mucus is a good thing, even though it's kind of disgusting.
Mucus is actually a very good thing. It has a lot of protective qualities, both from the fact that it traps bacteria and things in it so that we can blow it out. And it also has a lot of immune function in it as well. There's a lot of immune cells that are within it, and also a lot of immune chemicals that basically can kill fungus and kill bacteria and viruses that are always trying to find ways to get into our body.
And the filter you talked about are the hair in your nose, that's kind of your filter?
That's one of the big filters. I mean, that's kind of the curtain, I guess, inside,
Right.
to start into the nose. And then, the mucus itself is kind of a filter, and just the way that the side walls of the nose have convolutions, it makes the air travel in a certain way that kind of, allows all of our lining to feel what's kind of going down the pipe into our lungs.
Okay, let's talk about the itis. When I spoke with Dr. Kest, I said there's an itis that goes with everything.
Right.
And the swelling and all of that you were talking about, is that sinusitis? Is that right, sinusitis?
Well, I'm very specific on what terms I use when I
Okay.
talk about infections in the nose.
Okay.
And in general, there are a couple of things that I consider. There's rhinitis, which is essentially a generic, infection or inflammation in the nose. And that again can be allergic rhinitis, which is related to allergy. It can be a viral rhinitis, or the common cold. It can be a bacterial rhinitis. Now, when you add the sinuses into it, I really make a point to separate the nose from the sinuses. And the sinuses are really the cavities in our skull that are in various locations, again, that have functions to humidify and to make mucus and that type of thing. But when those cavities get infected, especially with bacteria, then we have essentially pus or abscesses in these cavities. And that is what we typically think of as the sinus infection.
Okay.
And those are typically the type of infections that we would think about putting somebody on an antibiotic for.
And those cavities, where if you were having possibly a sinus infection, sinusitis, where would you be hurting?
Well, it depends on which cavities are infected. We have two cheek sinuses called the
Okay.
maxillary sinuses.
Right in here under the eyes, where that
Right.
pressure.
Exactly. We have two forehead sinuses called frontal sinuses. And then we have a big honeycombed, collection of sinuses called the ethmoid sinuses that are the ones that are right between the eyes going back in. And then the final cavity, sinus cavity, would be the sphenoid sinus. And so depending on where those, what's involved would depend on maybe where that pain is. But it's even more difficult than that. There was a real interesting study one time that put stimulus at different locations in the nose and said, okay, where do we hurt from that stimulus? And you'd think, okay, if I put it right there, it should be right there. Well, sometimes if you put it there, it's over here and up, so it's not as defined as you might think. And so then when you factor in the different type of things that you can see, allergy, viral infections, bacteria, with the differing type of symptoms that you might have with it, the different type of pain phenomenons, the different congestion and everything, it makes it real difficult for both the patient and even sometimes the doctor to really figure out what's going on, because each one of those conditions, allergic rhinitis, non-allergic rhinitis, sinusitis, are treated very differently.
Wow. I just wonder how it all fits in there, how it all fits in there. But you said, so rhinitis is just the nose. right? And then it could branch out into
Right. We like using the term rhinosinusitis for sinusitis, because when you have an infection in the sinuses, really you also, by definition, really have it in the nose as well.
Okay. And how do you know that you have that? What would you treat for that? Like, what are the symptoms are, of course, pressure. What are the symptoms of sinusitis? In case someone's at home thinking, okay, do I have just my nose? Do I need to go see an ENT? How do I know that I need to see somebody?
Right. Well, again, with the three main things, allergic rhinitis, non-allergic rhinitis, and sinusitis, the symptoms can be almost identical. Okay. And so usually with those three, you'll have congestion in the nose, mucus drainage, feeling run down. If it's more of an infection rather than allergy, you'll typically have low-grade fever and kind of feel bad, maybe with a cough. The difference between maybe viral infections and bacterial infections is usually related on the length of time that we see. If I've seen somebody that has, these type of symptoms for, a less than 5-day period of time, it's most commonly going to be the common cold. And so I typically try not to treat people with an antibiotic because it's, number one, it's not going to help them, and number two, the overuse of antibiotics can really lead to, resistant bugs that are going to be harder to treat. If that symptom complex doesn't get better in about a 5 to 7 day period of time, or tends to be getting worse, or is associated with, worsening fevers or other symptoms that would make us think it's bacterial, then we really are thinking, okay, we need to treat that with an antibiotic and really kind of zap it, even more.
So the longer period of time probably requires a different form of treatment.
Right.
And I want to ask you this, and maybe this isn't the right question for an ENT, but the over-the-counter, say that it is the common cold, or it's only been 5 days. You go to the store, and there is something for everything, but not something, there's something for each thing, but not something for like everything.
Right.
What's the best thing over the counter if you're having a runny nose and congestion and cough? I did this with my son. I was like, what do I buy?
Well, I tend to hate the all-encompassing combination medicines. They're marketed as being, you need this one because it takes care of everything, but if you don't have everything, then you're taking medicines that you don't need.
Right.
The big classes of medicines there's decongestants.
Right.
And decongestants work on those blood vessels that we talked about. They make those blood vessels close up so it gets rid of the congestion. They're decongestants. And in general, I'll use those when people are actively sick, but I don't like using them when people are, just having allergy and that type of thing, because I think that it's treating the symptom rather than the source of the problem.
So would you suggest then getting a different medicine for each symptom that you have versus trying to get something that does all of them?
Yeah, that's what I usually like to do because for two reasons. Number one, when they have the problem, it's better to specifically treat the symptoms that you have. And then if you buy that medicine today, and then later on you have the symptoms that may not be everything, maybe you just need a decongestant, well then you don't have the temptation to take the combination medicine when all you really need is the decongestant.
Okay, well let me ask you this.
Sure.
Is that okay if I buy a decongestant and a congestion medicine and a coughing medicine and I give all three of them to my son? Because that makes me feel like I'm giving him a bunch of more stuff than just that combination. It's a little scary for me.
Well, it's okay if they have those type of symptoms that go along with it. But again, if you treat them with a medicine that has a cough suppressant in it and they don't have a cough, then you're really giving them a medicine that they really don't need to do. And every medicine that you give has, potential to have side effects. And so I'm kind of a minimalist when it comes to medicine. I like treating with the medicine that's going to make the biggest difference and that has the least side effects.
Well, that question was for me.
Yep.
Because I just went to Walmart and had to go through all of that.
That's right.
So I appreciate that.
And then to continue then, the other types of medicines that are out there, there's the decongestants we talked about. There's antihistamines, which block histamine, and those are medicines that you take for allergy specifically. And so they treat sneezing, itchy, watery eyes, the things that we typically think of hay fever with. And then there's cough suppressants, obviously to suppress cough. And in general, I think they're good for people that are staying up at night and that type of thing, but I try to stay away from those as well because cough has a function to be, to get out. And then there's mucus thinners, mucolytics. like the Robitussin type medicines that thin out the secretions, that make it easier for people to expel
Right.
and to have thinner mucus to be able to get rid of the things that are accumulating.
And you talked about the allergies. I would think that maybe I would need to go to somebody else besides an ENT for allergies. But you really treat allergies and can tell the difference between the sinusitis and the...
Right.
That's important to go to an ENT.
Yeah, I guess the benefit that I wouldn't say that I can provide anything that's any different than a general allergist or a general ENT that doesn't do allergy. I guess the advantage that I have is that I have all the tools of my trade available. So if you come to me with these symptoms, again, we talked about how you might not know if your congestion and runny nose is allergy or non-allergy or a sinus infection. And so, when you come to me, you don't really have to know. You can basically come with your symptoms and I can figure it out for you. And if you have, allergies, then I can treat allergies either by medicines or even by, doing allergy tests or injections. I can do sinus surgery because I'm trained to do surgery, or we can, treat the other sources, whatever we figure out.
One-stop shopping with the ENT. That's right.
That's a good thing.
You talked about surgery. How do you know that it's time for surgery for the nose?
Well, there's a couple of different indications. In general, to kind of just make it general, it's for people who have either chronic infections that aren't getting better. We have some people that you treat them with antibiotics for 3 or 4 weeks and they just don't, get better at all. Or for people who have chronic recurrent infections, if they're having more than 5 or 6 bouts in a year, or if even less if they're really bad episodes. In general, again, I'm a minimalist. If I can get people better with medication and not doing a sinus surgery, that's always going to be the better thing. But if they're not getting better, then either there's going to be allergy issues that need to be cleaned up, or there's going to be anatomic issues in the nose that need to be corrected. In other words, opening up the sinuses to get them to drain better.
Again, like Dr. Kest had said, when the risk factors from taking antibiotics chronically outweigh the surgery, you need to do that.
When the risks of the antibiotics, or quite honestly, when it's impacting people's lifestyle enough where they just can't keep going on and doing what they need to do. And there's plenty of studies out that show that even though when you have heart disease, that is a big life impacting thing. But if you compare it with some of the effects of what people have with chronic sinusitis, sometimes the effect of these diseases are actually very comparable or even more.
Well, because you may not know you have heart disease, but when you have sinus pressure and your nose is constantly running, you know that every day.
Right.
It's just every day you have the same things going on.
Right.
I wanted to talk about something that you talked about, the anatomical, is that my husband had to have surgery for a deviated septum. He couldn't breathe very well at night on one side, and he had to have that fixed. Is that what you're talking about?
Right. That's one of the anatomy differences that we can see. In other words, if the septum is the center wall of the nose, it divides our nose into two. And so if that septum is straight, then you're going to have good airflow through both of the sides of the nose that goes back. You get that feeling of, I'm breathing good through my nose. When there's either an injury that causes the septum to bow, or some people are just kind of really born with it, then that septum can bow off to the side of the nose and really block the breathing, and that can make mucus stagnate. That can interfere with the way you breathe, and that's just one thing. There are also things on the side of the nose around where the sinuses actually drain that can block the drainage of the sinuses, and when you block the drainage of the sinuses, then you're going to predispose them to really get infections, and those can be just normal structures that are too big. It can be normal structures that have some of the sinuses grow into them, or it can be polyps or just swelling in general that causes the blockage.
And you also, of course, that operate on the sinuses when the medicine doesn't work. I wanted to move on to something that interests me. We have a couple minutes left in this segment, and I wanted to ask you a couple questions about the ear again. The loss of taste and smell. Some of the research, the allergies and the treatments for that, and that one of the things they're saying now is that Alzheimer's patients are having a loss of smell and all of this. How does that correlate? Because I can't taste. I mean, I can't taste, and how does that affect that it's my nose?
Well, taste is actually mostly smell. And if you think about what your taste buds do on your tongue, you know, it's sour, sweet, you know, those type of things. The flavors that you actually taste are really from the particles traveling up to the upper part of the nose and going into the smell centers of the brain. And that's actually really tied into actually some of the pleasure zones in the brain, and that's why we're so attached to our eating, is because it's in that same triggering area in the brain. And so the way sinus infections and sinus and allergy can affect is if anything is blocking the passage of those flavors up into the top of the nose, then you're just not going to be able to see. And typically we see it with people that have polyps or just some deviated septums or other things that just block the air currents to go up to the nose.
So in conjunction with all the other problems that you may be having, if you have a loss of taste, that may be another symptom of what's going on in your nose and in your sinuses and stuff.
Absolutely.
Well, we're finished with this segment, but I wanted to go back to the nose the ear for just a second. You talked about why do kids get more ear infections, and how can we help prevent them from getting ear infections? What's a way of prevention?
Well, there's a lot of things, and these, ear infections have been one of the things that have been studied, like crazy to be able to try to find out how can we make these kids better. There's a protective effect of breast milk. When you breastfeed a child, the mom's actually giving the child some of her own maternal antibodies that actually can help that child, especially when they're young, but actually even on a long-term basis, to help prevent infection. So if you're going to do one thing, certainly breastfeeding is one thing to think about doing. We know that if we have a child that's around other children, in a daycare setting or in a babysitting setting where there's more than 3 or 4 children, then that child's going to be more at risk to get infections in general, and ears being one of those. And that's because if you've ever watched them, you'll watch them take a toy, put it in their mouth, give it to their friends, they put it in their mouth. They're basically a not so nice term as a petri dish effect, where they're basically spreading that infection all around.
Which goes to the throat, which again ties all back to...
Absolutely, absolutely. So certainly limiting daycare type exposures is a good thing. And in today's day and age, that's almost impossible for some people to do. Certainly hand washing is a big thing. I'm a big fan of trying to encourage that, because just like what we talked about with the daycare, if you can get that stuff off of their hands, then they're going to prevent it from going in the mouth. And probably one of the biggest things that we see is not smoking. Do not smoke around the child. Quite honestly, I'd love for people not to smoke at all, because again, that just inflames the aerodigestive tract and makes it real bad. Some people will say, well, I don't smoke around my child, I smoke outside, and it gets in the clothes, and then you still are bringing that around. And certainly there is a very strong correlation with ear infections and sinus and respiratory problems with kids that are exposed to any kind of secondary smoke.
And Dr. Kest really hit on that when in the first segment. I wanted to, this is just for me too, by the way, the Q-tips.
Yes.
I know you're using the Q-tips out there. Should we clean our ears with Q-tips?
Well, you can't put anything in your ear canal that's any bigger or any smaller than your elbow. Is that what Mom said for us?
That's what she said.
And so, no, you should not use Q-tips to clean. It's probably okay just in the outer part of the ear canal to use it. But when you start putting anything in the ear canal, first of all, a Q-tip is pretty big and it acts like a muzzle loader. You're really packing that wax. You're getting some out, but you're really packing it down in there. And anything else, I mean, we probably see, a couple people a month that have done something where they've tried to clean something out and went too far and had a hole in their eardrum or a cut in their ear canal. So it's probably not a good idea to do that. And earwax actually has a function. It's there to prevent infections from happening. There's actually protective effects of having it in there. And so you just got to let it do its job.
Okay, Dr. Resser, I know that, but I'm a mother of a little 5-year-old that I cannot leave that earwax in that canal because it just makes me think that his teacher's saying her mother doesn't clean his ears. He's dirty. Right. So it's okay if I just do the canal and don't go into the ear.
Don't go in the ear canal.
And go into the ear. Right. Okay, hun, lay off the Q-tips. Can't have any more. Dr. Resser says so.
That's right.
We'll be right back in just a moment. We're going to go to the throat. Stay with us. Welcome back. Again, I have with me Dr. Randall Resser, an ENT specialist here in Paducah, and we're moving on to the last letter of ENT. We're moving on to the throat. Since you crushed me with the Q-tips on the ear, that's okay. I'm just teasing. Just teasing. One of the things that I wonder about is I've always heard that you can have tonsillitis and strep throat. Strep throat was my best friend as a child. I had it every 6 months on the dot. It just loved me. But we'll start out with tonsillitis. There's the itis for the throat. What is it?
Well, a tonsillitis is when you have an infection or inflammation in the tonsils, and the tonsils are basically collections of lymph node tissue on the sides of our throat. And actually there's a couple of different tonsils in our throat. We have the pharyngeal tonsils, which are what people think of as adenoids, which is tonsil tissue in the back of the nose, kind of where the nose curves down into the throat. We have palatine tonsils, which are what everybody thinks of as regular tonsils. We have lingual tonsils, which are tonsils on the back of our tongue. And then all throughout our digestive tract, there's tonsillar, little patches of tonsillar tissue all throughout. So,
really?
So when people say, I've got a tonsillitis, what they really probably mean is they have an infection in the palatine tonsils.
My throat is sore.
That's right.
My throat is sore, that's all I know. Okay, and strep throat. I always thought that strep throat was a certain type, like bacterial or viral, and tonsillitis was the other. Is that true?
Well, again, a tonsillitis is just the generic term. So
Okay.
a tonsillitis could be bacterial, and the most common one would be strep throat,
Okay.
a strep bacteria. That also can be viral, though. It can be the common cold causing inflammation there. It can be mono, which is a specific type of virus that can cause an infection, and usually a fairly long-lasting infection. And then again, allergies can even cause an inflammation just in the lymphoid tissue back there, would cause technically a tonsillitis. But when we talk about a tonsillitis, we're really probably implying that it's more of an infectious cause than anything.
Okay, and possibly just when you have a cold and the drainage that goes down your throat just makes your throat raw and sore.
Sure.
So that's just that itis, just that generic kind of sore throat thing.
Right.
But the strep throat actually is caused by something, right?
The strep bacteria.
Okay.
Right. And that is something that, when you talk about viruses versus bacteria anywhere, really, viruses typically, there's some antivirals you can use, but for the most part, they're things that you just kind of have to get over, as opposed to a bacterial infection, the strep, which really would require an antibiotic to get over it.
Well, for me, having a sore throat was one thing, but when I had strep throat, there were a whole lot more symptoms that came with that.
Sure.
I was so fatigued and so achy and so run down. It just took everything out of me.
Right.
Is that a normal kind of symptom?
Yeah, a strep throat is usually a more severe type of a tonsillitis, and it can be associated with the typical things you think, fever and sore throat and that type of thing. You can get a rash from it, what we call a scarlatina rash. And we don't hear so much about some of the rheumatic fever and some of the heart and kidney effects that sometimes you can get with strep throats. But in the past, certainly people would get damage to their heart or even damage to their kidneys from that type of an infection. So.
Because the reason I said it is because my doctor would say, you are so susceptible to strep throat, you could walk by somebody on the street and get it. Mm-hmm. And they are what he called carriers. They had it, but they never got sick.
Right.
What is that about?
Well, the tonsil tissue, the way it's built, it has a lot of folds in it, what we call crypts. And that allows the tonsil to actually see what we're swallowing so that we can have an immune response. If it was smooth as a cue ball, it would just go past and you wouldn't be able to do anything. And that's a good function for the tonsil. But it also can be a bad thing. You can get bacteria trapped in those pockets. You can get food debris caught in those pockets. Some people have, white patches that come out of the tonsils. And so what can happen is some people will be carriers. And some people will have that strep that normally lives in the tonsil, and it just waits for an opportunity to come out. So if you have a viral, if you have a cold, that cold then can turn into a strep throat because of the fact that your body's trying to fight the virus, but then the strep comes out and starts kind of, causing havoc. Because
Waiting for me.
Absolutely, absolutely.
But we talked about that the ear infections are more susceptible in children.
Mm-hmm.
And since I've grown up, I don't have strep throat like I used to.
Mm-hmm.
Do children get that more?
That's common. Typically, we see more strep throat issues. I mean, it can still happen in young kids, but I think we probably see it more in age 3 to maybe age 12 is probably the more common range that we see. And again, the kids are more prone for infections in general. Again, probably due to hygiene issues and due to the fact that they're around other kids that are sick and that type of thing. And so that's right. So if you're prone to kind of have those deep folds in the tonsils, then you probably are more at risk to actually have strep that will come out and cause problems.
Okay, a friend of mine, you talked about those things getting stuck, and hers would turn hard. Like she could actually reach back there and it would be like a calcium deposit or something. And I had never seen anything like that. So those pus pockets that I would see at the back of my throat when I knew I had strep throat actually progressed farther with her to...
Those are called tonsilliths or tonsil stones. And when food particles or even just debris from the tonsil itself gets caught in there, you can actually get a little calcium response and everything. And typically, those are maybe the reason why I do or consider a tonsillectomy in an adult, because of the feeling that there's popcorn husk caught in the throat, or sometimes if you ever have seen them, they're actually a pretty foul-smelling thing, because the bacteria of the mouth get on there and they can cause bad breath and that type of thing. And so some people are actually able to kind of force them out and use either a Q-tip or a water pick to kind of force them out, but sometimes if they are really bothering people, we'll take the tonsils out to try to relieve that.
So let's move in. That's one scenario when you might go ahead and give a tonsillectomy. What are some other reasons why you might perform a tonsillectomy?
One of the more obvious reasons would be if the tonsils are so big that they're causing sleep disturbances in children, obstructive sleep apnea. And what I like to hear from the parent is not just that the child's snoring and making a lot of noise, but actually having those pauses of trying to catch their breath, and almost to the point where the parent's ready to wake that child up. And so we know that if they're experiencing that, they're not getting a good night's sleep, and there's a potential to not do well at school because they're tired all the time. And there has actually been some studies that show that some of the growth hormones are secreted at night, and so that may interfere with some of the normal development of the child. Probably not in a way that we would absolutely say, oh, that child has had tonsillitis, but little subtle things that might affect the child later on. The other infections are the other indication, and that's probably one of the greatest debates that's going on. It seems like our field swung from one side to the other on not doing any tonsils to doing a ton of tonsils to kind of going back and forth. And we like to at least hear that somebody's having at least 4 infections in a year, or more than 3 infections for a couple of years in a row. But if you look at some of the literature that's out there, you could get indications for as high as waiting for 7 episodes of strep throat in a year. And if you've ever had a strep throat, that's a lot of strep throats to wait for. Right. So what I tend to do is look at the numbers, but also look at how it's affecting the child. And if they're missing a lot of school or really being impacted by it, then I can make a case to do it a little bit sooner.
Well, there's a new advancement in tonsillectomies. Tell me a little bit about that.
Well, one of the things that a tonsillectomy will do is the recovery can be kind of difficult for some kids, because it's a sore operation, especially in adults. Adults are really, have a lot of soreness associated with it.
Is it worse in adults?
It tends to be worse in adults, and I can't tell if that's because those tonsils are socked in more, or if we just complain more about it as adults.
Right.
So there's been a bunch of different types of instruments, different ways of doing it, lasers and all kinds of things that have come out in the past, trying to find that way of doing it to reduce our side effects, but also improve the recovery and improve the pain threshold that people will have. And the newest thing that we're using is something called a coblator, and it's an instrument that has an irrigation system hooked up to it. It rinses the tonsil as we're doing it, so it cools the tissue as we're getting it out. It has a bipolar cautery associated with it, so it cuts the tissue and also seals the blood vessels as we're doing it. And it does it in a way that doesn't indiscriminately give you that real deep, pizza burn, on there, and it also has a little suction, on the tip as well. So it really it's been pretty amazing the way we can get kids to not have so much pain. We're seeing less pain medication use. We're seeing a quicker return to a normal diet. And quite honestly, from an OR standpoint, it's a quicker way of getting it out, and it's not 15 different instruments, so there's less confusion and less difficulty in doing it just from our OR staff doing them.
Well, I'm for anything that's faster and less painful.
Absolutely. Well, that's it.
That's it. The covulation tonsillectomy?
That's right.
Hey, all right. Well, I just wanted to you talked about the adenoids. My son had tubes, and they went ahead and took out his adenoids because he was doing what you talked about.
Right.
He was having trouble breathing at night and snoring, and I didn't know. But when the doctor looked back in his throat, they were almost touching, which is why he couldn't breathe well at night. So is that a thing for parents to look for? When you look down their throats and there's like not a very big opening.
Sure. The way a tonsil looks is important. Obviously, if you have big tonsils, you're probably going to have more problems than the smaller ones. But it's the symptoms that are probably more important to me. If you have huge tonsils but no symptoms, I'm probably not going to be taking out your tonsils. But if you're actually having, I tell parents to watch them at night, not just listen to them, but watch and see what's happening. And if they're struggling, if they look like they're really struggling to try to get that breath in, or if they're pausing their breathing, or restless all night, or tired during the day, then those are probably, tonsils that are blocking the breathing passage off at night and probably need to be taken out.
Because that's scary.
It is.
That your child can't breathe very well.
Right.
And you talked about the symptoms of the ear infection again. How do I know? Because when you have a small child, you don't know what's going on. I mean, you might be able to look at the throat, but that's a gift, to be able to really get down into a child's throat and be able to look and see what's going on. What are some symptoms for parents to look for? You talked about with the throat, not being able to breathe and restless. Sure. What about the ear and maybe even the nose? What should parents look for?
Well, certainly if they're tugging at their ears, if they have, irritation and not sleeping well at night are some things that we'll see. Nighttime is bad because when they lay down, actually the pressure of any fluid that might in there might be worse because they're not, it's going against gravity when you lay down. Certainly the things that you normally associate with an upper respiratory infection, fevers, runny nose, those type of things can sometimes be from the ears. But sometimes really ear infections that are just the fluid on the ears, what we call a fusion in the ears, sometimes are extremely difficult to figure out and may just be associated with a little bit of a hearing loss, because those type of infections don't necessarily cause the sickness that you would associate with an ear infection.
And sometimes what if they're a little dizzy or a little wobbly?
They can be a little off kilter, yeah.
Okay.
Sometimes you'll see that.
So that's some things for you to look for with the ear, the nose, and the throat. I want to thank you so much, Dr. Resser, for joining me. I really appreciate all the information that you've given us. If you have any questions, please feel free to call Dr. Resser or Dr. Kest. And we've broken it down for you, the ear, nose, and the throat. Hope you enjoyed. Stay with us for the next edition coming up soon, and we'll see you next time.